is sometimes useful in diagnosis of disease, and usually it is useful to understand the extent of disease, and it is always useful in planning surgery and minimizing complications. So imaging is mandatory prior to sinus and skull-base surgery. Application of imaging to assess the anatomy for disease localization and for assessment of pathology. Sometimes it guides to diagnosis with high accuracy, like juvenile nasopharyngeal angiosarcoma, inverted papilloma, invasive fungal sinuses. Many diseases by imaging we can diagnose with high accuracy. We will talk on radiological anatomy of sinus and skull base. Assessment of anatomy is very important because there is tremendous individual variation. Why we should know the variations for meticulous surgery and to avoid complication during surgery. Anatomy. Here the anatomy of sinus, lateral wall of the nose, and skull base. Spatial features of the sinus and skull base structures are oriented in three planes. It planes axial or horizontal. It divides the body in upper and lower parts. Coronal plane or frontal plane, it divides the body in front and back parts. And sagittal plane, it divides the body into right and left parts. Coronal section. For study of the structures disposed in horizontal and sagittal planes, those structures which are disposed in horizontal and sagittal planes, like floor of the orbit. This is a horizontal structure or axial structure. It can be seen by coronal image. If we do an axial image, we will not be able to see it. So for structures which are disposed in horizontal plane or sagittal plane, like nasal septum, this is placed in vertical or sagittal plane. So coronal plane can demonstrate it. So before requisition of imaging, which structure we want to see, it is important. Axial section, the structures which are disposed in vertical planes, coronal and sagittal. Coronal and sagittal structures can be seen by axial sections. And sagittal plane, the structures disposed in horizontal and coronal plane can be seen by this. The maxillary sinus, we can see the medial wall, anterior wall, posterior wall, and this is nasolacrimal duct. This is indentation for the infraorbital vessels and nerves, and this posterolateral wall is related to the infratemporal fossa. Posterior to the maxillary sinus is the pterygopalatine space, and this is the coronal section. Here we can see the uncinate process, and this is the floor of the maxillary sinus. The molar and premolar teeth are related to it. This is the base, and this is the apex pointing laterally, and this is towards the nasal cavity. This is the maxillary ostium. The next slide, we can see the posterior relation of the maxillary sinus is the pterygopalatine space. This is the medial opening is the sphenopalatine foramen. This is the pterygopalatine space. This is pterygomaxillary fissure leading to the infratemporal space. This is pterygopalatine space in sagittal section behind the maxillary sinus. This is a pyramidal space. The base is above and the apex is below. We can see the pterygoid process. This is the lateral pterygoid process, and this is medial pterygoid process. And muscles attached to this lateral pterygoid process, the lateral and medial pterygoid muscles. The space anterolateral to and lateral posterolateral to the posterior wall of the maxilla is the infratemporal fossa, and the space posterior medial to these muscles is the parapharyngeal space. So, while doing surgery in the sinus and skullbase, we have to know all these things. Sometimes malignancy in this space or infection in this space can spread to this infratemporal fossa. And some diseases from the nasopharynx may spread to the parapharyngeal space. So, this is the nasopharynx. We can see this is the tubal elevation. This is the tubal opening, and this is the fossa of Rosenmuller. So this is the commonest size of nasopharyngeal carcinoma. The parapharyngeal space nowadays divided into different parts. Previously, we used to divide this space into, this is styloid process. We used to divide this in pre-styloid and post-styloid spaces, but nowadays it is divided. The functional classification or division of this space is, this is the fat space. This is the fat space of the pharyngeal space, and this anterolaterally, this is called the masticator space. Any tumor, although rare, spreading from this area pushes the space or encloses the space from anterolateral part, and this is called the parotid space. This is called the stylomandibular canal. Any tumor from the parotid pushes or encroaches the space from posterior lateral, and this is called the carotid space. This is non-contrast CT. In contrast CT, we can see the vessels, carotid vessels, interconjugular vein, and this any tumor in the, and here also the vagus nerve. There are some lymph nodes in the carotid space. Any tumor arising from this space encroaches the space from behind, and this is called the mucosal space. Any tumor from the nasopharynx or oropharynx, in this section there is only nasopharynx, oropharyngeal or nasopharyngeal tumor pushes the space from medial side. So, by seeing the shape of this fat space, we can assume the origin of the tumor. So, knowing this anatomy and this modern classification is important for this reason. Another important thing here is the pre-sinus fat space. We can see the pre-sinus fat space is the hypodense area. This is the fat space. Invasion of infection or tumor from this maxillary sinus or any area to the fat space is an important finding. Like here we can see the minimal infection in the sinus, but fat space is obliterated or partially obliterated here. Here the fat space is normal. So this is one of the signs of invasive fungal sinusitis. Here the infection is more more aggressive than this part, but the fat space is normal. So this is not a sign of invasive sinusitis. Okay. Any tumor from this area may spread into this space and also to this muscle. These muscles may be malignant tumor spread from the sinus to the invade the fat space. So knowing the importance of fat space is now the ethmoid. Dr. Patwari has said about the lamina. I don't have to say more about this. We can see here the radiological lamina. After the transient process, first lamina, second is the anterior wall of the bulla, and third is the basal lamina and down lamina or basal lamina. Fourth is some says the superior nasal concha, and somebody says 5 lamina, the anterior wall of the sphenoid. So 4 or 5 lamina we have to face when doing the basics of the face. And one thing is here, we can see this is the bulla equinoris. Sometimes bulla is posterior wall is fused with the basal lamina. So after removal of the bulla, we face the basal lamina. This is usual, but sometimes this fusion does not occur. This is an anatomical variation. So there is a space. This is called retrobular recess. Retrobular recess. So in that case, one lamella increases. One lamella is the anterior wall of the bulla, another lamella is the posterior wall of the bulla, then the basal lamella. So in this anatomical variation, there is 6 lamella. This is not normal. This is an anatomical variation. And normally or usually the ethmoidal bulla fuses with the base of the skull. So after doing the bulla, superior one is the bulla. But sometimes there is a recess or space. This is called the suprabular recess. And sometimes this bony lamella is absent. The frontal recess become continuous with the suprabular recess. Ethmoidal air cells, to assess the anterior group and posterior group, when we see the image of the eyeball, the related cells are anterior ethmoidal cells, and behind that or in relation to the orbital apex, these are the posterior ethmoidal cells. This is the cross division and this is the basal lamella. And in coronal section, when we can see the vertical attachment of the middle terminate, this is the vertical attachment attached to the skull base. This is vertical attachment. So the ethmoidal cells seen here are the anterior ethmoidal cells. And the cells, ethmoidal air cells, when we can see the horizontal attachment of the middle terminate, we can see this is attached to the lateral wall of the nose, lateral wall of the maxillary sinus. So this is the third part of the middle terminate, and the cells are the posterior ethmoidal air cells. Now the sphenoidal sinus. We know the sphenoid sinus are sometimes usually asymmetrical. The septum is maybe in the midline, maybe laterally present. Sometimes one side is well lemmatized, another side is not well lemmatized. There is tremendous anatomical variations. And, the important structures related to the sphenoid sinus are the internal carotid artery, which is related to the posterior lateral wall of the sphenoid sinus. Here it makes an indentation, and the optic nerve, which causes indentation on the anterolateral anterosuperior wall of the sphenoid sinus. Sometimes there is hyperpneumatization or excessive pneumatization of Onodi cells. Now, how we will understand which one is the Onodi cell and which one is the sphenoid sinus? The anterior wall of the sphenoid, this is the anterior wall of the sphenoid, just above the nasopharynx. This is the anterior wall. Related to the anterior wall of the sphenoid is the sphenoid sinus. And always we have to remember the superior. If there is two cells, the superior one is the Onodi cell, or sometimes it remains superlateral. Superlateral or superior one is the Onodi cell, and inferior one is the sphenoid cell. In this Onodi situation, the optic nerve makes an indentation or related to the Onodi cell. Now the frontal sinus. There is again many variations in the frontal sinus. It may be pneumatized on one side, excessive pneumatized on one side, very less pneumatized on the another side. There is asymmetrical septations, incomplete septations within the frontal sinus, and there is variation in the pneumatization of the frontal recess. Again, as I said, pneumatization of the agandazi cell is again variable. Maybe small agandazi cell, may be very big agandazi cell. If there is very big agandazi cell, it causes narrowing of the frontal drainage area, and minimal inflammation may cause frontal sinusitis, frontal headache, intermittent or chronic sinusitis, polyposis, and something like this. And in the frontal recess area, there are other cells as well. This is the bulla ethmoidalis. If there is large bulla ethmoidalis, it can also cause narrowing of the frontal drainage pathway. So during surgery, this area is very important for frontal sinus. And we see the bulla ethmoidalis. This is fused with the skull base. But in one previous slide we have seen there is a recess in between the bulla ethmoidalis and skull base. So before surgery, we have to know the anatomy of that particular individual. Otherwise, we may make injury to the skull base, or we may do the surgery incompletely. We can see here the aganasal cell. This is the bulla, this is the suprabular cells. This is the frontal recess narrowed by the suprabular and aganasal cells. And this is the hourglass appearance of this frontal recess and frontal sinus. The frontal sinus tract, actually there is no tract. This is the tract caused by the cells. No actual tract here. Again, we see here the frontal recess area, frontal sinus, aganasal cells. In this slide, we see the bullite modalis, and it is not fused anteriorly. So, there is a suprabular recess, incomplete recess, suprabular recess. It is continuous with the frontal recess area. Lateral wall of the nose, osteometal complex. Dr. Patwari said many things about that. This is the osteometal complex, medially lamina papyracea, laterally, and medially the middle turbinate, and there is the this is called infundibulum, covered by the uncinate process. And when we remove the uncinate process, this is called the infundibulotomy, and maxillary antrum becomes maxillosteum becomes open. Now the middle turbinate. We have there are three parts: anterior part or first part, middle part, second part, or third part. So, in some cases, we remove the middle turbinate for surgical purposes. In that situation, we have not to avulse the middle turbinate. We have to cut a through-cut process, so like on any sharp instrument or microdebrider, so that we don't break the skull base and cause iatrogenic fixed leakage or meningitis. So here we have to cut the middle turbinate, not avulse the middle turbinate, if it is needed for surgical purpose. This is the vertical part or anterior part attached to the skull base, and second part is attached to the lamina papyracea. This is an oblique part, oblique. So we have to we will see it in another next slide. And this is the third part attached to the lateral wall of the nose. This is the horizontal attachment, oblique attachment, second part, and horizontal attachment is the third part. Here the skull base is anterior and this is posterior. We can see it is a vertical attachment of the middle turbinate. This is the oblique part or oblique attachment. This is the round lamina, and this is the third part attached to the lateral wall of the nose. This is the horizontal part. In relation to this part are the posterior ethmoidal cells, and in relation to this are the anterior ethmoidal cells. The basal lamina divides the ethmoidal cells into anterior group and posterior group. For the purpose of drainage, these cells drain into the infundibulum or hiatus seminaris area, and this drains into the sphenoethmoidal recess or posterior meatus, superior meatus. Middle turbinate. This is the vertical attachment, the anterior part. This is the middle part attached to the lamina papyracea, and this is the third part attached to the lateral wall of the nose. These are the posterior ethmoidal cells, anterior ethmoidal cells. This is the basal lamina. Now the anatomical variations. Uncinate process. Its superior attachment may be attached to the lamina papyracea, may be attached to the skull base, or may be attached to the middle turbinate. This is the most common, about this 85% cases, and sometimes there are double attachments attached to the lamina papyracea, most common type, attached to the middle turbinate and attached to the skull base. So we have to know the uncinate variation of the uncinate process during removal of the uncinate during uncinate toning to avoid unwanted injuries. Here the CT scan, you can see the uncinate process is attached to the skull base. Here uncinate process attached to the middle turbinate, and uncinate attached to the lamina papyracea. Now the suprabular recess, retrobular recess, and simularis superioris. Now we know the hiatus simularis. Everybody know the between the bulla and the uncinate process is the eccentric space which opens into the middle meatus is called the hiatus simularis, and it is also called sometimes called hiatus simularis inferioris. And another one is hiatus simularis superioris. What is that? if there is some anatomical variation causing space between this lateral lamella and this is the gula econolis. If there is incomplete fusion or failure of fusion between the basal lamella and the ethmoid, there is a recess. This is called reticular recess. And sometimes it also fails to fuse with the skull base. So there is supraocular recess. Sometimes there is only retrogular recess, there is only supraocular recess, or sometimes both are fused to cause retrogular and supraocular recess. This combination is called hiatus simultaneous superior. Sometimes we have seen in here the only part of supraocular recess is present, which is continuous with the frontal recess and frontal space. So we have to know before surgery if there is supraocular recess or not. Otherwise, we may think that this is the skull base and there may be remaining disease here. So, if we don't know the complete anatomy of that particular patient, we may do incomplete surgery, or we may cause unwanted injury. Now, there are some anatomical variation in the frontal sinus, frontal recess areas, excessive modal air cells. You know, this is the frontal beak, this is the nasum, corresponding interior bulging, backward bulging in the sinus is called frontal beak. Above the frontal beak is the frontal sinus. And sometimes the agar nasal cell is the cell above the inferior turbinate, the anterior most ethmoidal cell, and above the agar nasal cell, if there is a single pneumatization, single cell is type 1, and more than one type 2, and if there is a cell extend into the middle, into the frontal sinus, less than 50%, more than 50% type 3 and type 4, and we have to know all about this. If there is remaining pneumatized, we may think, if we don't know prior to the operation, we may think that the operation is complete, we have cleared the frontal sinus, but actually frontal sinus is behind and above that, and there may be incomplete surgery, and the frontal drainage remains narrow as it was previously before surgery. So we have to know all these things before surgery. This is supraocular ethmoidal cell or frontal sinus cell, and this is from behind, and there may be some cells there, and so if we don't know these things, we may leave behind the disease. Sometimes there is septal interfrontal septal pneumatization. Another is maxillary hypoplasia may be there. If we don't know this previously, we may injure the orbit. We may think this is the medial wall of the maxilla, we remove this one and we may enter the orbit. So maxillary hypoplasia, we should be careful about this, because we may injure the orbit. And maybe very hyperpneumatized maxilla, tooth roots may be exposed in the sinus. After tooth extraction, there may be oroendal fistula. Dental infection may extend into the sinus. So there may be hyperpneumatization or hypopneumatization of the maxillary sinus. And there is a cell on the inferior wall of the orbit. This is called the halar cell. If the halar cell is present there, it may cause narrowing of the maxillary ostium, or osteometal complex may be narrowed by this presence of the halar cell and block the drainage area by minimal inflammation. Now the cribriform plate. Keros classification has been mentioned previously by Dr. Patwari. Now, what is the importance of Keros classification? Less than 3 millimeter. So there is lateral lamella. This is called lateral lamella. This is called the sometimes called medial lamella, or sometimes called the cribriform plate. It is the olfactory fossa. Lateral lamella, medial lamella. So this is also the depth of the fovea equimodalis and cribriform plate. The depth between the two is maybe very deep. It may be very deep, more than 8 millimeter. This is called Keros type 3. And this is type 2, and the 3 or less is Keros type 1. So what is the important? If there is long lateral lamina, there is chance of injury of the lateral lamina is more during sinus surgery. And another important thing is that there is chance of mesenteric anterior turbinate is terminate here, and during surgery we may injure the anterior artery. So two things. One, we may injure the lateral lamina, and another thing, we may injure the anterior artery. So we have to know about the karyotyping of the individual patient before surgery. There may be asymmetric lateral lamina. We have mentioned that when which one is the onody cell, the superlateral one is always onody cell and infralateral one is always sphenoid cell. If there is confusion, and if there is onody situation, that is the hyperpneumatization of the post-ectomal cell, the optic nerve may protrude into the onody cell. Sphenoid, it is the usual location. There may be protrusion of the reach or exposure of the optic nerve into the onody cell. So during surgery, we may injure the optic nerve in the ethmoid sinus, not the sphenoid, in the ethmoid sinus. Here the onody cell, this is the optic nerve, CT scan, optic nerve, carotid artery. There is dehiscence of the bone. So we have to see for any dehiscence of the optic canal or carotid canal. In about 25% cases, there is bony dehiscence in the carotid canal in one or other side. And optic nerve, about 4% cases, there is bony dehiscence over the canal. Variation in the middle turbinate, there may be pneumatization of the middle turbinate, or we will call it concavulosa, which causes narrowing of the osteometal complex or pressing over the uncinate process and narrowing the maxillary sinus drainage area. This is pneumatization of the middle turbinate, and there may be paradoxical middle turbinate. That is, middle turbinate usually is convex medially, but it may be convex laterally. This is called paradoxical middle turbinate. Importance is that it causes narrowing of this area. To avoid danger of injuring the vital structures, we have to remember the acronym CLOSE. C for cuticle plate, L for lateral lamina, O for onody cell, S for sphenoid and skullbase, and E for ethmoidal artery. Karyotyping, we have told about that. Karyotyping. In case of karyotype or advanced 2, we may injure this lateral lamina or CSFT or atherogenic meningitis. So we keep our forceps away from the middle turbinate and towards the lamina preparation. And we have to cut by the edge of the forceps, not by the tip of the forceps, to avoid injury. And again, we can see the anterior ethmoidal artery lies in a mesentery in the ethmoidal cavity, so we can easily injure this artery. And we have to see the lamina preparation if there is any dehiscence, maybe congenital, maybe iatrogenic, or maybe by disease process. Congenital dehiscence in the lamina preparation. By the disease process, lamina preparation is eroded, and by disease process. So, if there is onody cell, we have to remember that optic nerve may be exposed in the onody cell. So we have to be aware of that. And our forceps direction always should be inferomedial direction, not superlateral direction. In superlateral direction, we may injure the optic nerve, and this is optic nerve. That's optic nerve, optic canal. This is optic canal, optic nerve. In this CT scan, we can see there is dehiscence of the optic canal. So optic nerve is exposed here. Carotid artery. Internal carotid artery is exposed here. So we can injure the carotid artery while doing the surgery within the sphenoid. Here we can see this is the carotid artery. Here the pneumatization is very minimal, small sphenoid sinus, but here very well pneumatized sphenoid sinus in this side, and there is dehiscence in the carotid canal. About sphenoid pneumatization, in case of hyperpneumatization of the sphenoid sinus, here the bone may be very thin and we can injure the even brain stem. and the sloping of the skull base. There is variation in the sloping of the skull base. You can see there may be sphenoid may be above the level of the skull base, and then the basin shape may be flat or sloping. So we have to know about the sloping of the skull base of the individual before doing surgery. Now the E of the close, the last acronym. That this is the anterior ethmoidal artery. We can see somebody says nipple point and somebody says bird beak. পাখি ঠোঁট এটা nipple point এর মতো এখানে একটা পয়েন্ট আমরা দেখতেছি। This is the exit point of the anterior ethmoidal artery from the ophthalmic artery to the ethmoidal ascens, then goes to the anterior cranial fossa, then to the nose. So this is the bird beak appearance, exit point of the anterior ethmoidal artery. It exists between the medial rectus, inferior rectus, lateral rectus, superior rectus. And this is the supraoblique muscle. Between these two muscles, the anterior artery comes out of the orbit through the labial deviation. So, mesenteric middle anterior ethmoidal artery, we may injure here. So you have to remember whether it is exposed or in the mesenteric situation. So to keep out of danger, we have to remember the acronym during reading the scan of the patient before surgery. Thank you all.